The vertical freedom philosophy is about that. It's not just about the tooth preparation.
We have a case with a light recessions. Can we use this BOPT approach to manipulate soft tissues without surgical approach?
Absolutely. You can dominate soft tissue.
With a BOPT, we have many possibilities to design soft tissue.
Yeah, it sounds magic.
It sounds like magic without
Yes,
surgery.
but it is not. It's reality.
Dear colleagues, greetings from BG Academy. We have a very special topic in BG Dental Talks dedicated to vertical preparations and BOPT concept. Today we have a special guest, Stefano Conti,
Nice to be here.
one of the world famous prosthodontists and implantologists working with vertical concepts, vertical preparations in implantology with a clinical experience more than 30 years.
Yeah.
And he is one of the inventor of the philosophy that is called vertical freedom. And today we are going to discuss with you what is vertical preparations, what is the BOPT concept, what is the difference between BOPT, vertical preparation, what is the limit between BOPT and the horizontal preparation, chamfer, and all this stuff that our colleagues are really confused with, and this is the day where we are going to clarify everything.
Absolutely, yes. See, many people think about vertical preparation, and I think that not many people really understand the real power of vertical preparation. So, all over the world, we have so many different techniques, but the one we make it here is the vertical freedom and BOPT concept, which is completely different.
That's actually one. Sorry to interrupt. Yes. I will be interrupting you sometimes.
Yeah, of course.
Because I have some questions that people asked already, and I would like to go straight into the point.
Absolutely.
As you said, there are so many confusions because vertical preparation, knife edge,
feather edge,
prepless, BOPT.
Yes.
Can you just clarify what is the difference between the named topics and BOPT, for example?
Absolutely, yes. I mean, the main goal of BOPT and vertical freedom is to go through vertical preparation, manipulate soft tissue. So it's not just about the tooth preparation. We have to invade the sulcus sometimes. And eventually, and I will show you later for complex cases, we can invade the biologic with as well. So this is a complete different concept. By doing this, we achieve the space, I will show you later, to manipulate soft tissue.
Okay, so as far as I understand, BOPT is more about soft tissue management.
Correct, and prosthetic approach.
And prosthetic approach rather than just preparation to create space for the restoration for dental technician to blend the transition from the restorative part to the tooth.
If you look at the history, 70, 80 years ago, they did already vertical preparation. But if you don't understand how can you, through the prosthetic, manipulate and dominate soft tissue, then you don't get the real advantages of it.
Just to clarify about the manipulating of the soft tissues. For example, we have a case with a light recessions. Can we use this BOPT approach to manipulate soft tissues without surgical approach?
That's the best indication. You know, you have many alternatives to achieve the beautiful final outcome. But if you work and think differently out of the book, then you can actually, going through the preparation, with where you got the recession, and work day by day with the proper timing and design in order to achieve the proper positioning of the gum.
Yeah, that's interesting. That's really curious. I'm curious to ask you just briefly. I know that that's a big topic and it needs to be, studied more deeper. But in few words, if you have this recession, light recession, let's say, and you do your BOPT, how actually it comes that the recession will be recovered?
You know, there are many different ideas about it. What I know, what I see every day is that when I do my preparation, I just create a horizontal space. So yes, I think horizontal, but in reality, I'm working on an horizontal space.
That means that you make tooth a bit thinner?
Yes, I
creating more
get the
space.
space horizontally by prepping vertically.
Okay.
And then with the horizontal space, I recreate a new prosthetic CJ.
The horizontal space is the space between tooth and the gum, right?
Correct.
Okay.
Correct.
Just to make everything clear.
Correct.
Okay.
So think about the horizontal preparation. You cannot interact with soft tissue. You have to prep where the soft tissue is. But when you think vertical, you just get into the sulcus. How deep? Well, it depends on the depth of the sulcus. It depends on the aesthetic need. But when you get into the sulcus, then immediately, while prepping vertical, you create a horizontal space. And if you know how to manipulate soft tissue with the prosthetic, well, the tissue will follow you.
You mean with the temporary restorations?
Starting from the temporary restoration, correct.
Okay, so
Correct.
BOPT is more about
Prosthetic.
precision in temporary restorations,
Absolutely.
designing the soft tissues.
Yes, the
And creating
vertical
this-
freedom philosophy is about that. It's not just about the tooth preparation, it's about veneers, no prep veneers, or even vertical prep veneers. It's about implants as well. All you can get along the vertical wall, all you can get in an horizontal space, then it can affect the final positioning of your tissue.
That's interesting. Just before we go to the next chapter of this topic, I would like to ask you the indication, because there is another confusion, like, okay, where to go vertical, where to go horizontal with this chamfer, you know, the shoulder preparation. What's the difference where we can indicate that? In this case, I would certainly go for a BOPT concept rather than, let's say, conventional or horizontal approach.
Absolutely. I'm still with the conventional preparation. I'm not against that. But if you think vertical, then you find indication for all your daily cases. I mean, the best battlefield of vertical freedom, BOPT concept, when you're dealing with compromised teeth. Because you got a recession. So which is the alternative? Connective tissue graft, orthodontic extrusion, or pull out the tooth and place an implant? Well, if you think vertical, then you eventually can prep in the tooth, get the space, and then through the space manipulate soft tissue with the proper cervical contour of the temporary crown and the final crown. So the best indication is when you're dealing with compromised teeth.
Like teeth with the recessions, teeth with the old crowns, with the violated
Correct.
biologic width,
Correct.
inflamed periodontium.
Correct. Got inflammation, you have to remove all crowns, you have a recession of 2-3 millimeters. That's not much. So you have to think, what am I going to do here? I got 3 millimeters of recession. Should I go through a flap, a connective tissue graft, or I can get the same result being patient and day by day with the proper timing and design achieve the same result.
Okay, that's interesting. You said 2-3 millimeters, so that can be a limit for a BOPT approach or not?
Theoretically, no. In my experience, of course, I don't get more than 2-3 millimeters, not because I don't trust the technique, because sometimes maybe you should also think by the book. So it's not magic. You should think like the perio approach, the perio establishment is still the one it works. So it's not an alternative to a perio treatment. But it's a good alternative to our daily work, like a recession of 2-3 millimeters. You always, every day we have to deal with this kind of problems. So it's a very minimally invasive approach if compared to other techniques.
Okay, understand. So another indication could be a teeth without ferrule, like
yes.
endodontically treated teeth with the old crowns broken up. You have the root, but the root is relatively long, let's say. Can it be used, I mean, a BOPT approach to treat these teeth rather than extraction?
Yes, absolutely. I've done many cases like this. You have the anatomical crown is poor, okay? You don't have enough ferrule. So what do you do? Well, you can get with the burr deep inside, and in this case, I'm allowed to invade the biologic width. I know it sounds weird, and the periodontist will try to say something about it. But again, which is the alternative? Should I raise a flap or have a slow orthodontic extrusion in order to get the right amount of tooth to recatch the ferrule? So always think about the alternatives. And in this case, the alternative is minimally invasive. With the burr rigor inside, you create the right amount vertical, but also horizontal, in order to reget and recatch the ferrule, and then from there start with the prosthetic.
Okay. If you have a case, for example, let's say posterior tooth, premolar or molar, with, let's say, very deep distal caries defect, which is really subgingival in connective tissues already.
Correct.
And we use the BOPT approach in such
Absolutely,
cases?
that's the best indication. Because the alternative, margin relocation.
Yeah.
The alternative, crown lengthening. Again, you can do it, you can still work by the book. I'm not against this. I come from that. But then I learned that if you do approach that way, you keep it simple.
Okay, nice. So basically, with a BOPT, we have many, like, let's say, possibilities to design soft tissues. Like, for example, in the recession case, we can somehow get the soft tissue going up.
Yes.
Right? But in a case when you have no ferrule, for example, then you prep down, and then your soft tissues will be lightly down, right?
Exactly.
So we can play both ways.
That is called vertical freedom. It's not about just the coronal movement and positioning. It's also about the apical positioning. So you can move up and down depending on the case, depending on the clinical situation.
Okay.
So it's a huge advantage.
So like a case, let's speak about non-compromised teeth, but we have a natural teeth, aesthetic case, and high smile line of the patient, two central incisor, one zenith is more coronal, another one is more apical.
Right.
And we want to move the one that is shorter, more apical, to get the zenith there. So we can do gingivectomies, for example, or?
Perfect. You're allowed, normally, I'm telling you the story, normally when you have a compromised gingival architecture in between the central incisors, what do you do if you think by the book with an horizontal line? You need to get to the upper line. So if one central incisor has got the zenith, which is more apical, probably you have to think the same. So you want to get the zenith of the other tooth exactly the same level, so you go apical. So thinking horizontal, you got only one way. Thinking vertical with this kind of concept, you just think both ways. So what I can do, if I need to prep the teeth, I can get the tissue a little bit more coronal on the center with the zenith too apical. And then in the same time, I can get the other zenith, which is a little bit too coronal, a little bit more apical. So let's say I have a discrepancy of 3 millimeters. I got 1.5 millimeters on one side and 1.5 millimeters on the other side. And I get a perfect zenith.
Sounds like
Yeah, it sounds magic.
Sounds like magic without
Yes,
surgery.
but it is not. It's reality.
Okay, and how much time it may take with all this approach, with the temporary restorations?
Yeah, some people, many colleagues tell me, oh, Stefano, this kind of technique is kind of slow, takes time. I have to see the patient a couple of times in order to manipulate the margin of the crown. Okay, don't do it. Go buy the book. But again, which is the alternative? Think about the alternative. If you go by the book, you need a connective tissue graft eventually. And how long you have to wait for a connective tissue graft? 6 months. To make sure that soft tissue is stable. With this technique, in few months, you can achieve beautiful results. How you do that? Step by step. First day, you do the preparation. With the preparation, you do not demand tissue to follow you in the first day. But what you got a soft tissue thickening. When the soft tissue is thicker, then it's going to follow you. With the proper timing and design, you're going to work on the margin of your temporary, and then day by day, soft tissue is going to adapt on the margin of the temporary. The margin of the temporary is your landing zone. The margin of the temporary is the preparation line.
Yeah, that's interesting, because that's another question when you do vertical preparation. Our colleagues are confused. Where is actually the finish line? Because there is no finish line. So where is the crown, potential crown margin, and how we can teach our dental technician or say to our dental technician that we want to have a crown at this position, for example?
Yeah. Well, first thing first, follow nature. Look at nature. Nature is going to tell you where's the finishing line. But we have rules. It's very easy. Assuming that we prep the tooth and we start conditioning tissue with a temporary crown. Finally and eventually we achieve a beautiful gingival architecture. When we get the beautiful gingival architecture, we need to transfer all the information to the technicians. So the rule is simple. We should look at the nature. And normally, the new prosthetic CJ that you got with the temporary crown and the final crown is exactly where the CJ of a natural tooth is supposed to be.
Okay, but once we play with the different zenith positions, for example, we are doing the new CAJ, for example.
Yes, because we got the freedom to move. Every day a little bit the margin of these crowns. What about what about if I want to, for example, to achieve a final positioning of the tissue 2 millimeters more coronal, because I got the recession? Well, the day zero, I'm going to prep the tooth. I'm not expecting the tissue to follow me for 2 millimeters. So what I do, I support the tissue with a temporary crown. Then after 20 days, a month, let's say 4 weeks as average time, I can shorten the temporary, create a little bit of a space, and then magically, soft tissue will adapt on the new landing zone. 20 days later, I can do the same. How much? 0.5 millimeters, for example. And then again, soft tissue will adapt on the new margin, on the new landing zone. That way, in a few months, we can achieve a new final positioning of the gingival margin.
Yeah, that sounds really interesting.
It
so
is.
Basically, you are growing the gingiva by manipulating with the temporary restoration.
Absolutely. You can dominate soft tissue. Okay. I know it sounds incredible, but it's really like this.
As far as I understood it, I would like to clarify if I get you right.
Yeah.
So when you do your preparation, you create horizontal freedom, so the space between the tooth and the gingiva.
Correct.
By that means the gingiva will become thicker because it has more space. And by the thickening of the soft tissues and the positioning of your temporary crown, you can determine the position of the gum you want.
Exactly.
So at the certain day, the gum will be here, for example.
Yes, correct.
Then you make the temporary shorter, 0.5 millimeters.
Correct.
And the gums follows you.
You got it perfectly.
20 days you can move.
You got it perfectly.
Okay.
Of course, the diagnostics is fundamental. So when you approach the patient, what do? You do the probing and sounding. How far is bone below gingiva? 3 millimeters. Okay. Do I need to get my gingiva level apical? Well, I need to invade the biologic way that way. It's like a little osteotomy. It's a little crown lengthening. But most of the time, eventually, unfortunately, we need to do the opposite. We are dealing with a recession. So how far is gingiva? How far is bone below gingiva? 3 millimeters. Okay. And how much do I need to reposition coronally my soft tissue? 2 millimeters. So at the end of the day, I'm going to create a new dentogingival complex of 5 millimeters. And I'm doing it slowly. Okay, day by day. By prepping, I create the space, I have a soft tissue thickening. Then after 4 weeks, I'm shortening the temporary, and then soft tissue will follow me. And then, at the end of the day, if I choose to define perfectly the final positioning of the margin of the gingival architecture, I can work also on inclination on my margin. So if I work on the inclination of my prosthetics, then again, I can manipulate soft tissue in a perfect way.
Okay, so this is actually your task, your job. I mean dentists,
yes.
not dental technicians.
Yes.
Just to clarify, because our colleagues, actually one of the most important questions is how we teach dental technician to do that. We want the gingiva to be here, our dental technician needs to know something. Yeah. But as far as I understood, we have to do it ourselves with our temporary restorations before our dental technician will come into the game, right?
Correct.
Okay.
We do it. As soon as we achieve the ideal gingival architecture, then it's our mission to give all the information to the lab. Mm-hmm. How do we transfer that information? We have many ways, but mainly to simplify 2 different avenues. One is analogical, one is fully digital. When we go analogical, you just have to follow the rules. So I'm giving you a perfect positioning of the margin, the gingival margin.
For example, you spend, like, say, 2 months with your temporary restoration, making relining, making the shortening, and so on and so on. So now at the end, you have the perfect profile.
Exactly.
And you need to transfer this into your dental lab. Okay. Yeah.
So I can take an analogical impression with the silicone, whatever. Then the technician is going to have a model, And the only reference it's got is the gingival margin. But with the gingival margin, the technician is going to design on the tooth abutment exactly the position of the gingival margin. And because of that, he knows exactly how apical to go beyond this gingival margin.
It sounds like the prosthetics on implants. When you have temporary
It's about the
restoration,
same.
you keep your patient with a temporary crown and implant, then you have a beautiful profile, and then you do a scan
Exactly.
transfer and whatever.
That's why I call the concept vertical freedom, because it's about implants as well. It's all about the prosthetic you can manipulate. Through the prosthetic, you can manipulate soft tissue. Doesn't really matter if you have to prep for a crown or a veneer or an implant. It's going to work the same.
Okay.
Yes.
So then, okay, with the analogic, it's fine. You just use your light body and a putty material, for example. You take an impression, and a digital way.
Digital way is the present and the future. Because digitally speaking, when you really want to duplicate the final positioning of soft tissue, it's not technique sensitive anymore. You don't need to give so many information to the technician. The best way, as soon as you say, after 2 months, 3 months, I've been working with the temporary, and now through my temporary, I achieve a beautiful gingival architecture of a central incisor, upper right one, perfect, and it's perfectly symmetrical to the upper left one, which is the best way to make sure that the final crown will give you the beautiful gingival architecture. Just copy the temporary. So we have a digital way to take a digital impression of the temporary and give the information to the technician. And by doing this, we are 100%, 101% sure that we're going to duplicate exactly what we've been achieving with the temporary.
Perfect.
Yes.
The last question.
Yeah, why not?
We speak about the growing of the soft tissues, which was really amazing. But for example, a patient came with this very old prepped PFM crown, and the margin is almost the level of the bone.
Yes.
So it's so violated. I mean, the biologic width is so violated, and we have to redesign the soft tissue. So literally, we have to go to the bone level, or sometimes even to the bone.
I'm not supposed to tell you, because periodontists won't like it, but yes, I do this as well. When comes the time, again, you need to make a decision, which is the best way to achieve a beautiful result, which is the most minimally invasive approach. It's up to you. Normally, if you think by the book, you should raise a flap, do a crown lengthening, right?
Yes, correct.
But in this way, if you know how to deal with that, you get the burr, and believe me, it's not a blind technique, because you see everything. You see perfectly, especially here in a beautiful state-of-the-art training center. You got a microscope. You see exactly where you're working with and where you're going to. So you just get inside, get to the bone, and create the verticality you need, the space you need to get to the final outcome.
Understood. Perfect. Yes. Thanks a lot for these open talks.
My pleasure. My pleasure.
I think our audience got a lot of answers and feedbacks and insights. And I really happy to invite you, my friends, to our course together with Stefano Conti, the true hands-on course dedicated to the vertical freedom concept and BOPT, where we are going to do preparations. We are going to show you how to
create the
temporaries,
how to manipulate soft tissue by manipulating the temporary
in anterior and posterior
area, and how to transfer all the information to the technician.
To the dental technician. Perfect.
Correct.
Thanks a lot, and
thank you.
May the dental force be with you. Now let's be honest. Okay, tough question, just between me and you.
Why not?
Molar tooth, distal cavity, very deep. You excavate cavity, you have undercut. You do composite restoration. Okay, so that's composite there. You prep to the level of the tooth. Okay, so your margin will be on the tooth, and you want to manipulate the soft tissues with the temporary restoration, for example. Yes. You put the temporary, then you make it shorter, the gum should follow you, then you make it shorter, gum follow you, but it will be on the composite.
Yeah.
What to do in such a cases?
Well, you want me to be honest, right?
So, to be clear.
First thing first, anytime you do vertical, you can decide to place the margin of the crown exactly where is the margin of your preparation, horizontal preparation.
Yes, correct.
So I have two different avenues. I can still make the crown exactly like you do, on the tooth. If I want to achieve, for aesthetic reason, a different gingival level, then I have to accept the compromise of deep margin relocation.
Or like, okay, recession. Recession and abfraction, okay, front area aesthetics.
Yes.
And sometimes patient comes with a filling there. There is a composite filling in the cervical area.
Yes.
Okay, so there is a filling, and you want to move the gingiva down, and there will be a filling there. It will stay there or not?
Absolutely, that's another indication. For example, sometimes without any prosthetic, without prepping the tooth, how can I manipulate soft tissue? I remove the filling, the old filling.
Yes.
I do prep root flattening.
Yeah.
Okay. I do prep a little bit into the sulcus. I clean up the recession. I go with the burr, which I got black marks, 1 millimeter into the sulcus. I create the space, and then I replace a filling, a composite filling. How? A bulky filling, because the filling is going to be again the landing zone for soft tissue.
Okay.
So it's going to work the same. Soft tissue is going to adapt on the filling. 20 days later, 4 weeks later, what I do? I shorten the composite. And soft tissue, which is thicker, stronger, got shoulders now, is going to follow me. That way, I can actually work with recession.
So soft tissues have to be in any ways on the tooth, not on the composite.
I'd love to be and think like this.
Okay.
I'd love to think like this. Absolutely, yes.
Okay.
Absolutely, yes.
Done.